everybody. So, as you all know, the hard cataracts have always been a challenge. So, hard cataracts are very common in diabetics, pseudoexfoliation, very hard mature cataracts, brown luminescent cataracts. If you're looking at one of these, my very old videos where I started doing hard cataracts and my technique was not, I was not very comfortable. So, after a good hydrodissection, the major problem with operating hard cataracts is once you chop, the chop does not extend up to the posterior part of the nucleus. So it is very difficult to chop the posterior fibers, though you will be able to do chop the anterior fibers. So the basic problem is chopping how do you do that is you have to debulk the nucleus in the central part as much as possible and hold the nucleus as deep as possible to get a good chop of the posterior plate of the nucleus. If you look at this case, I could do a part of it, but later on the pupil becomes small and the chopping becomes so difficult that I'm not able to remove the posterior plate. So finally what I had to do is I had to extend the nucleus, I mean the incision, and then I had to remove the nucleus. This is like way before I started doing the technique. So this is my dig and burrow technique. The rexis size remains almost the same as 5.5 rexis size. I don't change the rexis size. And the hydro procedures remain the same. You do a good hydro dissection. Only in the, just stay in the rexis area and don't extend too much. So what I do is, initially we do a very good central trench. That means make a central a burrow, a deep burrow like this, as posterior to the as posterior as possible. So once you use the maximum power possible, generally I use the maximum torsional power and make a very good central trench. So this is what I call is the central dig. So dig the central part as much as possible, so that what you're trying to do is you're doing you're going as deep into the nucleus as possible. Once you do that, you make multiple burrows like this. There's the first burrow, the second burrow, and then hold the in the third burrow hold the nucleus and then chop. So what you're doing is you're debulking the nucleus. So this is the first burrow, this is the second burrow, and this is the third burrow. Once you do the third burrow, hold the nucleus there and then crack. So by this, you can actually almost reach to the posterior plate, and you can almost have a complete chop. So second burrow, this is the third burrow, and now the third burrow, and hold the nucleus with the maximum parameters with high vacuum, and you can have a complete chop. The basic advantage of this technique in comparison to what Dr. Ravindran sir has done is, Ravindran sir actually takes the chopper way beneath the capsulorhexis, and from the equator he chops it. So basically in this technique you can still stay in the rhexis margin itself within the pupillary area, and then you can actually chop the nucleus. So once the pieces are separated, then you can use the soft shell technique, where you coat the endothelium with viscoat, and then, so I have used the viscoat. So and then you can actually once I don't use the second instrument after I have chopped all the pieces. So what is the most important tips in this technique is, you should have a good exposure of the phaco probe, at least of 2 to 3 mm, so that the sleeve does not stop you from embedding into the nucleus. If the sleeve is too anterior, then the tip may not actually embed into the nucleus. The central dig should not extend into the periphery. Make as many pieces as possible, and the soft shell technique is compulsory. So it is its advantage of vertical direct chop can be done in small pupils, and chances of breaking the rhexis is very less, and there is no undue pressures on the zonules. Thank you.
Wonderful technique. I think, are you using my chopper?
Yes, sir, that's your chopper.
You didn't mention that. You have to pay some money for that also. Yeah, you're not giving me, say, any my loyalty for that. Whatever it is, a beautiful technique. Vertical chop is the way to go in hard cataracts. Horizontal chop, you can do that. Only problem is in the vertical chop, in the horizontal chop, because these are cataracts which have got nucleus and more nucleus, and there's no very little cortical cushion there. So horizontal chop is from the equator. So vertical chop is right in front of the rexis. Horizontal chop is a little blind technique. Vertical chop is directly under a direct visualization. So we use a sharp chopper for vertical chop.
I think for the vertical chop that you have to hold the nucleus and bring it slightly anterior, and the other instrument should put pressure down, and the handpiece should put pressure up.
Yes, sir.
Then it has.
And also, sir, what I would suggest is, when you use your vertical chop, go into the body of the nucleus, tilt your phaco probe slightly like this, not go tangential to the capsulorhexis margin or parallel to the capsulorhexis. Go slightly down into the body, because these are all very thick cataracts, about 4-5 millimeter more. So you can go and nicely bury and do a vertical chop. Lovely